Good morning, everyone. Thanks for joining us for No Stroke, How Acting Fast Can Save Your Life. I'm Calvin Hu with Family Caregiver Alliance, and before we get started, I'd like to say a few words about our organization. Family Caregiver Alliance has been working in the Bay Area and the nation to improve the well-being and quality of life of family caregivers. We offer support by providing a number of services and resources, including consultations, classes, workshops, publications, and we also do advocacy work both locally and nationally. To learn more about Family Caregiver Alliance, please visit us at caregiver.org. Now, your phones and mics are going to be muted, so if you have any questions, you can ask them by using the Q&A box on your screen. We will answer as many questions as we can at the end of the webinar. I'll also be asking you to give a little bit of feedback, so I'd like to thank you all in advance for filling that out. Now, finally, if there are any technical hiccups either on our end or yours, please just use the same link or login information you used to joining us today. So I'd like to welcome our guest for today, Irina Rebello. She's been a neuroscience program manager at Mercy San Juan Medical Center, which is a comprehensive stroke program since 2015. And she's also a volunteer for the American Stroke Association. Irina has been a registered nurse for over 22 years and holds a Master of Science in Nursing Leadership. She is passionate about providing access to stroke care and is a frequent speaker and facilitator of community events. So now that you know a little bit more about our guest, I'd like to turn things over to Irina.
Thank you so much. I'm so excited to be here with you guys today to be able to share a little bit about my passion for stroke care. A few objectives of what we're going to cover today. I'd like to share with you a little bit of an overview about what stroke is, some common types of strokes, what you can do to modify your risk of having a stroke, how you can recognize a stroke quickly, looking out for signs and symptoms, how you can actually prevent a stroke from getting to the point where you need treatment, and if you need to, treatment options for stroke and what you might expect afterwards. So to start off with, very basic stroke definition, what it means, it's injury or death of brain tissue from oxygen deprivation. So we know that our heart beats and takes blood and nutrients to all areas of our body, including our brain. So any sudden interruption of that blood flow, whether it's by something blocking the way or by something rupturing and creating a spillage of that blood into another area, and preventing it from reaching the brain, that's what leads to a stroke. It disrupts the pathway that carries oxygen and nutrients to the brain. And this is a life-threatening emergency. A couple slides on some stroke facts. Currently, stroke is the 5th leading cause of death in the United States. That's actually down a little bit from the 4th leading cause a few years ago. And that's due to the fact that people are recognizing strokes faster. People are seeking treatments in a more timely manner. And so we're making great strides in making sure that less people are affected by stroke. But that still leaves almost 800,000 Americans suffering from stroke each year. And when you put that into perspective, every 3.5 minutes, someone actually dies from a stroke in the US. And in the US, that also translates to every 40 seconds, someone suffers from a stroke. So it is still quite prevalent and something to be mindful of. About 185,000 of strokes, so that's nearly 1 in 4 of those that have strokes are people who've had a previous stroke. And so that's why I'd like to spend some time with you this morning talking about preventative strategies, because it's a huge part of stroke care, making sure that maybe we don't get to that point where we need the treatment and intervention. And when you look at the stroke division of types of strokes, there's two major types of strokes. 87% of all strokes are ischemic in nature, which means that blood flow is blocked by a clot. And the rest of strokes, which leaves about 13% of strokes, are hemorrhagic, which means they're bleeding strokes. And that's where a vessel has ruptured in the brain. And sometimes the presentation can be similar, but the care is different. So we're going to talk a little bit about those different things. This is from the CDC website. I just wanted everyone to just take a quick look at the prevalence of stroke. They are always a few years behind in compiling the data. But as you can see, I think most of the people joining here might be from the western half of the United States, maybe primarily from California. Maybe you're joining us from all over. Maybe you can kind of take a minute to find our area or the area that you're in on this map, and you can see kind of the adjusted rates here and the index about how prevalent stroke is in ages 35 and up. You do have different hotspots, especially in the southeastern part of the country, and we have some spots over in the western part of the country as well in different counties. So these are areas where there's a lot more incidence of patients that have the two types of stroke, whether ischemic or hemorrhagic. This is something that I'm hoping that everyone that's joining us today remembers. This is something that really struck me when I was learning about stroke, that up to 80% of strokes are preventable through risk factor management. And that's, again, a reference from the CDC, and all the facts you'll find on a reference slide at the end of the presentation, so you can double check and update yourself on more information if you're interested. But 80%, that's a huge number. So, you know, if we look at the risk factor management aspect of it, we could potentially prevent so much of this devastating disease. From 2001 to 2011, our stroke death rate fell to 35% from it was previously. And that, again, made us fall from the fourth leading cause of death to the fifth. And that's because of these type of educational programs where people are aware of what's happening, are aware of how to quickly recognize a stroke, are aware of how to prevent one. So hopefully this information will be useful to those of you that are attending today in that manner. Approximately 7 million stroke survivors are in the US right now. And there's different challenges that the stroke survivors face depending on how much of the treatment they're able to get, how much rehabilitation, what area of the brain was affected. But sometimes people regain function fully. Other times they actually have some major disabilities to deal with. This is a little graph I made that I'm using to teach our community and our nurses and our EMS to kind of figure out where we are in the stroke continuum of care. There's many different parts to stroke care, but it always starts with prevention. Just like any disease process, there are things that, you know, sometimes we can't, but there's definitely things that we can do to prevent. And so prevention is so important. After that, we want to talk a little bit about recognition, how to activate 911, and be able to come to the nearest stroke center that can treat you. The EMS component, emergency medical services, ambulance that gets there as quickly as possible, the treatment in the emergency department, what can happen sometimes in the inpatient setting, and then patients are rehabilitated and reintegrated into the community with as many resources as we can possibly help that patient population with. Primarily, I want to focus more on prevention, recognition, and arriving to the hospital because this stroke lecture is titled How Acting Fast Can Save Your Life. But there's definitely, I just wanted you to be aware, there's a whole continuum of care that continues after that initial treatment. So when we talk about prevention, there's a thing in the medical world, we like to say primary prevention. So prior to the disease actually occurring, these are discussions that you have with your primary physician to try and mitigate and recognize the risk factors that prevent that disease from occurring. On secondary prevention, that's where disease is already present. And you want to make sure you don't get to a further state of a disability. For strokes, the prevalence of a second stroke after you've had one is about 23%. So after someone has a stroke, they're at 23% higher risk of having a further stroke. So that's pretty high odds. So we really want to focus on preventing that from happening again. And then tertiary prevention, again, we want to continue on preventing the recurrent stroke, but we also want to reduce disability through patient rehabilitation as much as possible and help them regain complete independence and improve their quality of life. So that's kind of the things that your stroke centers around the country, those that maybe are near you, that's what we deal with on a daily basis. We want to make sure that we provide this complete picture of care for stroke that starts with education on prevention and then kind of continues through the acute phase, but also helps our patients regain independence and reestablish themselves in the community as much as possible. A little bit about non-modifiable risk factors. So these are things that we can't do anything about. Obviously, when we get, the older we get, the more disease risk we have. The risk of stroke actually doubles after age 55. Gender, men do have a higher risk of stroke, but women actually are likely to die from stroke more, and that's probably because women tend to live a little longer. So there's a couple of different sub-statistics, if you will, that compound that whole gender risk factor. There's family history. Of course, there's genetic tendency and lifestyle that contributes to that. Ethnicity, certain races are actually more prone and have a higher risk for stroke, also because some of the risk factors, the preventable risk factors are also more prevalent in that population as well. And then, of course, if you've had a prior stroke or heart attack, those can cause a higher risk of you having a stroke. On our modifiable risk factors, we're going to go over each one of these a little bit more in detail. I have a slide on each one of these, just because I feel like they're so important when we're talking about a disease process that is 80% preventable. It's so important to be able to look at each one of these things and see if they apply to us and see if there's something we can do, something we can take charge, something that will empower us to take charge and make sure that maybe we won't get to that point. And then if we do, maybe prevent a further one from happening, or our family members or anyone in our sphere. Just really important to be able to be aware of these different risk factors that are listed here. So starting with high blood pressure. This is consider high blood pressure that's higher than 130/80. And actually, most recently, that number has been decreased to about 120/80. And I have a slide that can show you kind of where you fall into, risk or actually consider high blood pressure or extremely high blood pressure. But if you can believe this, 30% of adults are unaware of their high blood pressure currently. And more than 40% of individuals with high blood pressure are not on treatment. This is the one risk factor that we see all the time as something that's present with almost every single patient that we see coming in that has a stroke. So really, really important to be able to take that seriously, talk to your provider, talk to anyone on your healthcare team and get that looked at. So here is a chart from the CDC that talks about what's considered normal. And like I said on the previous slide, there's usually, it used to be 130 and higher is high blood pressure, but 120 to 129 is already considered elevated. So we want to keep our blood pressure less than 120 on the first number, which is called the systolic, and less than 80 on the bottom number, which is called the diastolic. Anything above that, and this is considered in a consistent manner, not just like once or twice when you get upset about something or you're stressed, but this is something that we track and your physician tracks over time. And if you're consistently in one of these hot spots here, it's definitely important to be able to take care of that. So what do we do about blood pressure? Of course, healthy diet. Always look at things like low sodium, making sure we exercise and maintain a healthy weight. Those are super important. Exercise and healthy weight actually help our blood pressure reduce, not only by the benefits of the endorphins that we get from exercise that help relax our vessels and our blood pressure, but also, maintaining a healthy weight. We have less miles of vessels for our heart to be able to pump that blood through. So that's how that works. Definitely no tobacco. We'll talk about tobacco in a minute. That is one of the risk factors that we can do something about. Staying hydrated, especially in the summer. Sometimes we forget about that, but that's very, very important because dehydration can lead to our blood becoming a little thicker and blood clots forming. So we don't want to get into that area. And definitely stress management. We all know that stress can cause all sorts of underlying problems for many, many diseases. So important to be able to look at all these things. And obviously medication, talk to your doctor about medication and be on medication if you need to be to maintain your blood pressure within normal limits. Some of these medications are listed here. We're not going to go into them. There's not really a clear advantage to one particular type of medications. So there's something you have a discussion with your doctor and what works for you. But very important to address that. I cannot stress that enough. The next risk factor is obesity. This is another prevalence chart that just shows you where the hotspots are in the nation. What we can do about that, of course, we all know. We can, start a moving campaign within our own families, and recognize when we're full, recognize triggers for overeating and making better choices. And obviously there's medical assistance that's available for other causes as well. So those are some of the things that we can do to improve that risk factor and maybe hopefully decrease the chance of a stroke because of this as a risk factor. Now, diabetes. This is another important one. Between blood pressure and diabetes, those are the two risk factors that we see very, very often in the hospitals that I work at. So people with diabetes are 2 to 4 times more likely to have a stroke. If you have untreated diabetes, that can cause atherosclerosis, and this makes it a lot harder for the blood to get to the organs, especially the brain. So atherosclerosis, what that means is the vessels and the lining inside our vessels is damaged. And instead of being soft and pliable so that the blood pressure can go up and down, think about like a new hose that it's working perfectly versus something that's been sitting out in the sun, it's getting all hardened and crusty. And when you turn on water, sometimes it can leak or, maybe stuff can get in there and block it. That's exactly the same concept. If diabetes is not treated, those vessels become unable to get blood to our organs correctly. And it leads to increased fat deposits in our blood vessels. And those fat deposits can either narrow our arteries, or they can actually completely block them, or they can break off from one area and migrate to a smaller lumen vessel and completely block off the blood flow. So about 26 million people in the US, that's about 8% of the population, have what's considered pre-diabetes. And so these people are going to head into and going to be diagnosed with type 2 diabetes in the next 10 years. So once again, super important to have a discussion with your physician about the differences between the diabetic types and maintaining, for those of you that may be joining us that are diabetic, you know what this means, the hemoglobin A1C. That is a blood level that we track over time to see how well your blood sugar management happens, because blood sugar can just be a point in time depending on a meal you've had or maybe insulin that you've had, but hemoglobin A1C can tell us over the last few months how well you've managed that. So we want to keep that below 7% for diabetics, and definitely a lot lower for people that are pre-diabetic or people that are potentially heading into that direction. Again, super important things to talk to your doctor about. Take your medicines, manage your diabetes. Some other lifestyle factors that can help are a healthy diet. So eat fiber every day, exercise to maintain a healthy weight, and once again, no smoking. One of the next risk factors I wanted to talk to you about is high cholesterol. Cholesterol is basically fat deposits in our blood vessels. There's 2 different types of cholesterol. We term one good cholesterol. And that comes from, there's good fats and bad fats. So if we eat healthy foods that have good fats, fats are building blocks for cells in our body. So we want to have good fats, but these also can protect our body against narrowing our blood vessels. When we ingest bad cholesterol, or what's considered LDL, or low density lipoproteins, this can make our arterial narrowing worse. So those arteries that take blood to the brain and other parts of our body, they can actually start depositing on the interior of the vessels and make the narrowing a lot worse. So if we don't manage our high cholesterol, you can see how this can lead to bad outcomes for our blood vessels. And you can also start to see maybe a picture of multiple risk factors, how not managing multiple risk factors can, create such a much higher risk for potential stroke or heart disease. So this, if we have high LDL, so like the low density lipoprotein, which is the bad cholesterol, again, it leads to the disruption of our cell surface and it promotes inflammation. You guys probably have heard the term cytokine release. I mean, that's been in the news lately with all the COVID stuff that's been going around. So you can recognize that very quickly as something that's not good. And what it does is it leads to our mitochondria, which are the powerhouses of our cells, it starts to not function correctly and die. So there's several things that happen with high cholesterol. Definitely something to be concerned with. Definitely something to talk to your physician about. Lifestyle factors you can implement, and also medication you can take to decrease that. There was a very large heart study called the Framingham Heart Study. Once again, these graphs are taken from the CDC and one other reference that you'll see at the end of the slides, but ideal cholesterol is less than 150 milligrams per deciliter. And in the Framingham Heart Study, you can see here that there is such a decrease in prevalence of heart disease or of any cardiovascular disease in patients that had their cholesterol less than 150. So that seems to be kind of the magic number. As you can see right here on the right side, less than 200 is desirable for total cholesterol, but we want to keep it less than 150. And then further breakdown for LDL versus HDL. When you get your lab results and talk with your physician about this, you kind of see that breakdown of the two different kinds of cholesterol and where that might fall under as far as what's optimal and what would be considered high or bad. So these are the kinds of things that you can, we talked a little bit about what you can do about cholesterol. There's a healthy diets are advocated. Ideally, things like plant-based diets actually eliminate some ingested cholesterol. There is, of course, some hereditary factors. People that have high cholesterol sometimes can do all these things, but genetics do play quite a bit part in that as well. I did put a embedded link here to a video, which I cannot show right now because once we launch YouTube, it actually automatically goes into ads and kind of disrupts the flow of our presentation. But you do have access to that in the presentation as a link. But if not, you can just Google, how does a single high-fat meal paralyze our arteries? And it's pretty amazing. They actually can go in with very high-tech cameras and be able to see how even just after one, cheeseburger, how the little tiny vessels called capillaries at the very end of our blood vessels, that's where the oxygen and nutrient exchange happens at the cellular level in our bodies and with our organs, how that is actually quite impacted for quite a bit of time. I mean, it recovers. Our bodies are amazing at recovering things like that. But over time, the more and more and more they get hit with this kind of situation, it can lead to deposits of fat and narrowing of the arteries and those friable blood vessels that we talked about. Definitely exercising and maintaining healthy weight and no tobacco. If you are really into reading trials, you can look up the Sparkle trial. This is talking about what kinds of statins and why we recommend treating patients with medications to lower the cholesterol so that we can prevent any sort of disease from happening, like stroke or heart disease. All right, so we reached tobacco. It seems like every single one of those other risk factors that we talked about reference tobacco. So we know that cigarette smoking approximately doubles a person's risk for a stroke. This impairs our lining of our blood vessel. That's called the endothelium. So our blood vessels vasodilate, meaning they constrict and expand constantly based on what's going on with our bodies, based on so many different, very intricate cellular level demands that our body has. Our body is constantly working to maintain that kind of balance. And so what's happening when we smoke, it creates a problem with that vasodilation. It creates a problem with the blood vessels being able to dilate and constrict in response to the needs of the body. And it decreases it does this by decreasing a certain element called nitric oxide. It's actually a gas in the body that helps that vasodilation. And it actually increases the oxidation of LDL. We talked about that, the low density lipoproteins, which is the cholesterol that is bad. So smoking makes that worse. It increases inflammation markers in our body. It actually increases fibrinogen levels. So what that means is it increases the ability of the body to clot. You might think that's a good thing if you cut your finger or if you have an injury, but if you're just going along, there's no injury happening, and you have this your body doing crazy things like increasing its ability to clot. What that does is it creates more clots in your body. And as you remember, one of the biggest types of stroke is an ischemic stroke, where a clot blocks an artery, and it completely blocks the oxygen to the brain. We talk a little bit about electronic cigarettes. This could be useful as a stepping stone to quitting. However, there's concern with toxicology, meaning, actually poisons with aerosolized materials. So anytime someone inhales something, there's always other particles in there. A lot of people perceive this as less harmful, but it's actually not. This is a nice little graphic that we actually have it in a lot of our stroke lectures and a lot of our quitting smoking. Within 20 minutes when you quit smoking, your blood pressure and heart rate can drop to normal. And as you can see the progression here, within 8 hours, what happens? Within 72 hours, what happens? Within 2 to 3 weeks, what happens? And as you go backwards and you quit smoking, that last cigarette that you had, maybe in 5 or 10 years, maybe, some of these concerns that you have as far as risk factors could decrease significantly. So there is a lot of work to be had there. If you smoke and you're determined to get rid of that risk factor. So there's hope. I like this slide because it provides hope. Like there's some reversal that can happen, definitely. Chronic excessive alcohol intake is also bad. I mean, sometimes, we see different studies that say moderate intake is good for certain diseases, but then it's not. But definitely stay away from anything chronic. Excessive intake can actually cause a temporary increase in heart rate and blood pressure, and over time it will weaken our blood pressures. The recommendation currently is no more than 2 drinks per day for men and no more than 1 drink a day for non-pregnant women. I like to just put there are none. There's always better to stay away from it if you can. Resveratrol is a protective compound in wine that is also found in grapes with the skin on. So the grape juice and blueberries, mulberries, and raspberries, and all sorts of things like that. Sometimes you hear like, oh, wine's good for your heart or wine's good for your blood vessels. It's because of that compound there. And definitely drug abuse is the last risk factor we'll talk about. I don't think anyone will have any concerns or questions about this. Everyone knows that cocaines, amphetamines, and heroines are all really bad things. They actually increase the risk of a stroke by damaging those blood vessels pretty severely. And one word about cannabis. I know there's, lots of availability now for medical use and different things, but we have seen, and I have seen myself in my practice, that strokes are actually increased in the younger patient population because there's a specific type of stroke caused reversible cerebral vasoconstriction syndrome. We won't go into that, but it's, the word reversible may make it sound like it's something that is not so concerning, but it actually is. So just say no. And last but not least, atrial fibrillation. Those that have this irregular heartbeat know what I'm talking about. That's when your heartbeat beats abnormally. So because your heartbeat beats abnormally, there's areas in the heart that can kind of just pool blood in there and quiver and have a higher risk of forming clots. And those clots can actually go from your heart to your brain. So stroke is increased about 15% in people that have uncontrolled atrial fibrillation. And you have a much higher risk of death from stroke if you have uncontrolled atrial fibrillation that leads to a stroke, because these are usually large clots that can form there and block a very large area of the brain. For atrial fibrillation, there's different types you can do. Of course, talk to your physician. There's different things that they will prescribe as far as medications or maybe a procedure that can help decrease the chance of your heart beating irregularly and creating that potential for a blood clot. All right, so we've arrived at this part in our presentation where we want to talk a little bit about how to recognize a stroke. So you may have thought, okay, we're going to start with how to recognize a stroke because that's what I'm concerned about. But I think acting fast includes recognizing the preventative strategies that we can implement right now, and decreasing the chance of getting to the point where we need to recognize a stroke. And hopefully, if we do have a patient or ourselves or someone that it has a stroke, someone's nearby that can actually quickly see that this is a stroke and it's a medical emergency. A word about stroke is that it's not painful. It's not dramatic. Quite often, people are not very sure what's happening. If it's a mild symptom, just like maybe one thing, maybe they just have a little bit of balance trouble, or maybe just a little bit of blurred vision. You wake up and sometimes I wake up, my vision is blurred, no big deal. Like I just kind of tend to ignore it. Those are the kinds of things that we want to just focus on and not ignoring abnormal symptoms that are happening. Because again, it doesn't hurt. It's not dramatic. Nobody's clutching their chest. Usually people don't clutch their head. It doesn't hurt. A stroke usually is a silent killer because people usually tend to blow it off. But if we can start looking at some of these symptoms and recognizing these symptoms, we can definitely save someone's life. So first off, this is a mnemonic that we usually help disseminate onto the community. You may have seen it in an abbreviated form, but just saying FAST. There's two different versions. FAST just talks about face, arm, and speech difficulty. We like to use BFAST because it includes a couple other symptoms that are very prevalent as well. So starting with balancing, if you're noticing a patient that has balancing trouble, they're walking around abnormally, maybe sometimes people describe it as a drunken walk and there's nothing else going on, and maybe there's not something that could precipitate that, like alcohol ingestion. Definitely something to be concerned about. If it's not normal for them, that's something to be concerned about. Sudden eye blur, blurred vision. All these symptoms are going to be sudden. So I do want to reiterate that. Usually stroke usually happens suddenly. It's not those people that have slowly had balance trouble, or slowly their vision's going, or maybe their arms just weaker and weaker over the last few months. These are things that happen suddenly, just like that. They're going along, all of a sudden they're having balance trouble. All of a sudden their eyes are blurry. All of a sudden their speech is, their face is drooping. All of a sudden, maybe one arm or one leg is weak. And then maybe their speech is garbled. They're talking on the phone or something, and suddenly their speech becomes unintelligible. So those are the symptoms we want everyone to remember. Be fast. And the T, of course, stands for time. If any of these things are noticed, we want you to call 911. And one note of that here is we don't want you to get in the car and go to the ER. There's so many things that the EMS can start on that pathway, on that circle. Remember the circle slide at the beginning of the presentation on that care continuum? They can actually start the treatment process in the ambulance. And so we're delaying that quite significantly if we get in the car and drive us, or have someone drive us to the hospital. So here's a little bit more in detail. Sudden trouble walking, sudden trouble seeing, sudden numbness. The key word here is sudden. And I did add one thing at the bottom here that's not on the mnemonic. That's because a sudden severe headache, described as the worst headache of my life. Usually, again, it's one of those that is not the higher prevalence of the type of stroke. Sudden severe headache is a bleed. So that's someone that maybe has a burst aneurysm or a bleed inside their head. This is the one caveat about the stroke when I said it doesn't hurt. This type hurts, but this type is a lot less prevalent. You won't see this as much. Most of the types of stroke that you see are not painful. But if you have someone that suddenly has a severe headache, Usually they'll describe it as the worst headache of their life. Sometimes people say it's a thunderclap headache, meaning if you just clap your hands right next to your ear and you kind of feel that snap inside your head, that's considered a thunderclap headache. That is also a medical emergency. Could potentially be a hemorrhagic stroke, which is a bleeding type stroke. All of these things, time to call 911 so we can get you to the hospital and get you treated right away. As far as treatments for ischemic stroke, so there's several different things that we can do for you, but I just want you to, hopefully your eye is drawn to the text in red down here where it says time-dependent interventions. So there's not a lot of time. Time is brain. In our world, we talk about time is brain. Every single minute that passes by, we lose a lot of brain cells in these kind of situations. And so if any of those symptoms happen in that BFAST slide that I showed you, that's why it's so important to call 911 right away so that the medical team can evaluate and see if a patient qualifies for some of these interventions. So we're not going to spend a lot of time talking about these because they are quite complex, but two things that to remember is to treat a stroke, we usually give people something called a thrombolytic. So this is a medication that works by dissolving a blood clot and hopefully introducing blood back into the area that is being affected. These treatments can only be given usually less than 4.5 hours from the time the symptoms started. And then the other thing is that we can do is something we call mechanical thrombectomy. So that's actually a wire that goes in through the groin and goes all the way up into the brain and removes the blood clot. Again, all these things are time-dependent interventions, and the physicians and the medical team can do some evaluation and some diagnostic procedures in the ER to evaluate to see if the patient that's having a stroke actually qualifies for these. One thing that's really, really important here is knowing the time of onset. So the little clock here, the clock actually starts the minute someone has symptoms. And so for a lot of people, sometimes that's confusing because maybe they went to bed normal and when they woke up at 7 in the morning, they had symptoms. And so they say, well, I woke up at 7 and I had symptoms. But for us in the medical team, we have to take the last known normal time. So the last time that patient was normal was at 10 o'clock the night before. So as you can see already, then we're really behind the curve with the clock. And there are treatments available for people that wake up for strokes, but sometimes they happen as you're going along with your day. And then, here's the symptoms. Here's, when the clock starts for stroke. Hopefully there's family members at scene. Hopefully there's someone there that can say they were fine at 8 o'clock and at 9 o'clock, we were sitting down to have breakfast. We were talking and all of a sudden they have these symptoms. That's super, super important distinction because that's what starts the clock on this stroke treatment is the time that the first symptoms started. And remember, these symptoms are sudden. So we want to make sure that if there's somebody with us, as we disseminate this information out, that somebody's noticing someone acting abnormally, immediately notice the time that started. Of course, the medical team will do a lot of evaluation and delving into the history and trying to ascertain the exact time so that we can start the clock for these interventions. But it's really important for everyone to be aware of that piece of it. I embedded another YouTube video here that we don't have time to watch if you want to see what a mechanical thrombectomy looks like when they go in and pull the clot out with a catheter. There's lots of different videos on YouTube. It's pretty intense and pretty interesting to watch. And sometimes people have these symptoms. I've been right there next to them. They go in and they remove this clot and their symptoms are completely disappeared. Usually what happens is their symptoms take some time to disappear if they're going to disappear because the area of the brain that is being affected is a little stunned. And so we try and intervene so very quickly so that we can prevent that stunned area from actually dying. So when you have a stroke, you have an area of the brain that could be affected and a large area around it that could be just stunned and kind of paralyzed, but it could be potentially salvageable and saved. So we focus a lot of our interventions and treatments on saving that area that is stunned so that we can prevent further disability and create better outcomes. And I just want to finish a little bit with hemorrhagic stroke, because at the beginning we talked a little bit about there is about 87% of stroke types are ischemic in nature. So that means a blood clot or a narrowing of our arteries. Hemorrhagic strokes are about 13% of our strokes. These are bleeds. So they can be different types. There's one called intracerebral hemorrhage. So that's bleeding inside our brain. They can be subarachnoid. So that's a bleed that usually happens when there's a burst aneurysm. These are a less treatable form of stroke. They have a much higher mortality rate, but everything is still time dependent. If anything happens, like that sudden headache that we talked about, super important to get to the hospital, because supportive care is still very important for these types of patients, meaning intensive ICU, aggressive care to prevent any further injury after the initial the injury from the hemorrhage. A lot of these patients are medically managed, meaning they're in the ICU. We take care of reducing secondary injury, like I mentioned. Sometimes there's surgeries that can be done. And if there's an aneurysm that bursts, we can fix that by a procedure called coiling or clipping. And if you would like to see what that looks like, feel free to navigate to this link here, endovascular coiling for brain aneurysm, and it shows you what that looks like. Once again, pretty amazing that we have this technology and are able to do this right now. So if you'd like to navigate to the CDC or blood pressure guidelines, here are a couple references for you where I got some of the graphs that, and pictorials that we utilize in the presentation today. And I would like to thank you for your attention and following along. Hopefully I was able to provide a concise overview of stroke, and two things for you to remember: just those risk factors, if we can do something about that, and the be fast, how quickly acting, recognizing, remembering the time of onset for symptoms, and calling 911 and being able to get to the hospital for treatment. So once again, thank you for your time and attention. I'd like to open it up to questions right now.
Perfect. Thanks so much, Irina, for sharing your knowledge. We do have a lot of questions, and I guess right off the bat, we had a listener who wanted to know if there are any difference in symptoms between men and women. You mentioned that the kind of mortality or the seriousness of the incidence is slightly different between them, but are the symptoms pretty much the same between men and women?
You know, the symptoms are actually the same between men and women. The mortality, like you said, like you mentioned, is a little different. More men have strokes, but when women live longer. But sometimes women tend to ignore symptoms more. So as far as the presentation, it's the same. They're usually not something that you can say, oh, women have more of this or more of that. The sudden numbness, sudden confusion, face drift, arm drift, speech difficulties, pretty much across the board for both men and women.
Okay, we have another question from a viewer who wanted to know, you mentioned that time is brain, so kind of moments and seconds and minutes count, but is there kind of a quote unquote window period to get to the hospital that might be an acceptable window to get to the hospital, or is it really every, as you mentioned, really every moment counts?
So I do want to underline that every moment counts. There are different time periods that have interventions associated with them, but it's very important to get there as soon as possible. So the patients that have the best outcomes are patients that get there within the first hour and a half of symptom onset. Because, you know, as we go on, there's less chance of recovering that stunned area of the brain. It depends. It depends on age. It depends on prior risk factors. It can depend on how much collateral circulation do we have in our brain. Everyone's different. Everyone's brain anatomy is different. So we want to just be able to maximize that time that we have available so that the medical team can make the decision to intervene if we qualify. So definitely get to the hospital as quickly as possible. The first time-saving intervention, the thrombolytic therapy we mentioned, we cannot give that to you usually after the first 4.5 hours. There's a few exceptions to that. And then the thrombectomy can be done up to 24 hours, but that's not recommended. The best outcomes are for patients that come in within the first 3 hours for that.
Okay. We have a couple of questions kind of about, maybe I'll just lump them into circulation or one person wanted to know if poor circulation is a possible risk factor for stroke. And then another listener wanted to know if a superficial blood clot in a leg, I guess, versus deep vein, is that also a risk for strokes?
Yeah, so those are great questions. Definitely any type of poor circulation has an underlying reason for that. Is it because diabetes? Is it because blood pressure? There's many risk factors for that. Just poor circulation alone usually has some type of underlying issue, and that's what is a risk factor for stroke. Definitely poor circulation, just that's incidental, from being cold or things like that are not going to affect that outcome. But if definitely poor circulation usually is related to blood pressure, diabetes, or some other type of underlying disease. And I'm sorry, what was the second question?
Sorry, it was the let's see, it was the superficial blood clot in the leg versus deep vein. Is
Yeah.
that a
Yeah, so that's actually that's the same answer actually that applies for that. There's other risk factors that led to that blood clotting that can increase the risk for stroke. It just depends, is it a vein that is bringing that blood clot back into the circulation? That can, usually a vein doesn't do that. It goes back to the heart and affects certain other parts of the body. For strokes, it's the blood clots that are from the arteries that go to our brain. But again, it's the underlying risk factor. Why is there a superficial blood clot? Is there some other problem going on? Is there diabetes? Is there smoking that causes blood, friability to those blood vessels that can actually increase? So it could be it's like a sentinel, like, hey, if something's happening here, please pay attention.
Okay, we have another question, this anonymous question. They want to know short-lasting symptoms some time ago. I would guess maybe sometime is maybe days. What should be done now? And maybe, I guess, if anyone has experienced any of these fast symptoms in the past, what might you recommend?
So the question, as I understand it, is maybe the person's thinking that it's already been several days since these symptoms started and they have not gone to the hospital. So
Yeah, let's.
definitely, yeah. So definitely still don't, there is better outcome for people that present to the hospital within those first few hours. But there's definitely a lot that can be done after the time window for treatment has passed, because the body is still amazing. The body's still trying to either reabsorb the clot or do something to prevent further injury. So there's different things that we can do to prevent a secondary stroke or prevent further damage. There's rehabilitation that can be done to help the brain maybe learn a new pathway and perform certain functions that maybe were lost in that initial event that maybe didn't get treated. So definitely important to still go to the hospital. Definitely, if you've had these symptoms in the past, if fast happened, you had those symptoms, you didn't seek treatment, maybe there was some type of stroke that it was mild. Maybe you're not even noticing symptoms. But remember, 23% of those patients have a higher chance of a second stroke that could be the one. So very important to still seek medical care at that point.
Okay, thank you. We have another question, another listener who is taking care of someone with dementia. So they, I guess it's the person might be a risk of wandering, so they keep their door locked, as many of us do, just in general. But they wanted to know, I guess the kind of question behind this is, if emergency services know that you're calling about a stroke, are they able and willing to kind of break down a door if needed to get to that person, get them to the hospital in that really short time frame?
Yeah, so certainly EMS's primary goal is to get to the patient that called them and be able to provide very quickly, timely, assessment and taking that patient to the hospital. So if, hopefully there's someone there that can answer the door, that they try and, go around and see, but they don't lose a whole lot of time with that. If nobody's answering the door, maybe someone activated maybe one of those lifelines and they were alone by themselves and they couldn't get to the door. It's not ideal, but we definitely want to, save a life over saving a door. So they are going to intervene and go in and try and give care to whoever needs it.
Okay. We have another questioner who, it's a two-part question, but there's a pretty interesting part. One is they wanted to know what your thoughts about baby aspirin or aspirin in terms of the, I guess the ischemic strokes, the ones that are, blood clot related. And then this is really in particular framed around this is a person who lives in a rural area and might not have a great access to a hospital or an emergency department in terms of time, getting there in a timely manner.
Okay. So first, let's address the aspirin. Definitely, any medication needs to be taken or prescribed under the supervision of your physician. Aspirin is one of those medications that's actually, it is over the counter. It's been around for a long time, but if it had been, so-called invented in today's world, they would not have made it over the counter because it does have a lot of side effects. It does thin our blood a little bit, and it's still one of those medications that can prevent us from having a stroke, but that all has to be done under the supervision of a physician. Definitely patients that have risk factors or have had a stroke will be prescribed aspirin by their physician as a mode of treatment and preventing a secondary type of stroke, and other agents that work like aspirin. In terms of baby aspirin or aspirin, again, this all needs to be done under the qualified supervision of a physician, because there's different variables and different things that they look at and make sure that that is taken safely.
Okay.
So I just want to reiterate, if the concern is for prevention of stroke, very important that you have a discussion with your physician first.
Great. And then, sorry, I don't know if we discussed this beforehand, but I should have. But we wanted to know, a listener wanted to know if we'd be able to share the presentation.
Oh, of course.
Okay, great. I'm happy to, on my end, I'm happy to share it. Okay, so you know what, for that question, we will share it. I'll get a link up of the recording, and then there'll be a link to download the slides. So you won't have to do anything. I'll send that out to everyone who's registered. So everyone on the call should get that automatically.
Great.
Go
I
didn't
answer that second question with the rural area concern and access to hospitals. The cool thing about that is if you get set up with your primary physician, we have ways of getting you there fast. We actually have, I'm not sure where the person that asked that question lives, but in our area, we have people that get flown in. They actually are picked up from wherever they're at by helicopter, and they get flown to a center that can treat them quickly. Sometimes, I'm not advocating for anything, but sometimes those, specific memberships that are available for different types of air ambulances are a good idea in that sense. But as far as, most of the areas that we live in, we try and look at and see, okay, how many patients have access to like either a hub or a center or something, and how far away are they from that, by vehicle, by air ambulance, by something. So we really look at all those kinds of things, and certainly access to care is improving every day, but definitely encourage or discourage not calling and not activating 911 just because you think that you're in an area that maybe is less accessible.
Okay. And, we have another question, a clarifying question, I guess, about BFAST. If, say, you only have maybe one or two of those symptoms, would you still recommend the person calling 911?
Absolutely. Again, the key defining factor there is sudden. Is it a sudden onset of one of those things? Suddenly someone can't speak correctly. Suddenly their arm is weak. Or just one, suddenly their vision is blurred. Definitely that's how that mnemonic is applied. Any one of those symptoms, for sure.
Okay. And another question related to the presentation, you spoke in detail about the dangers of smoking for stroke, but what about secondhand smoke? Does that also increase the risk of stroke?
Absolutely. So secondhand smoke is actually worse. If you can, you may have heard this, but smokers, they inhale usually through a filter, where secondhand smoke is just disseminated in a room, and extra particles that are not, they're going to just be floating around in the air, and those people don't have the benefit of breathing through that filter, and it can be worse. So it definitely does what it does as far as increased stroke risk factor just as it does for smokers. And it also is secondarily a little bit worse as far as lung disease and other problems, just because of those extra particulates that usually live in the air.
Okay. We had another a listener who wants to know, I guess, a clarifying question, the difference between stroke and something called TIA.
Great question. So a TIA is something it's called a transient ischemic attack. So what happened, the key word is transient. So, and we talked about stroke being ischemia. So meaning ischemia is just the deprivation of blood flow to the area of the brain that if it's not intervened on, is irreversible. Transient refers to the fact that, there could be an area of the brain that has, a certain period of time, usually it's less than an hour, that they have symptoms and then that resolves on its own. Maybe it's a small clot that the body reabsorbed. Maybe the clotting factors, the anticoagulant factors of the body immediately kicked in and helped that. Maybe there was just a narrowing that vasodilation, meaning expansion and constriction of the blood vessels based on how their blood pressure was at that point in time, was something that returned to normal. But a TIA is basically like a sentinel stroke. So anytime someone experiences a symptom of TIA, which the symptoms are usually very similar, the key defining factor is that they go away usually pretty fast. Still very important to seek medical care, still very important to activate 911 and come be evaluated. You will not probably qualify for those treatments because there are no symptoms, but you still need that workup. You still need to see, okay, what's happening? What risk factors do you have that need to be intervened on and mitigated so you don't end up with a stroke?
Okay, perfect. I think we have time for just one more question. Actually, and you referenced this in a previous answer. So the listener wanted to know if you might recommend those kind of push button emergency devices, the ones that you maybe, I guess, you wear around your neck or like as a necklace, or would you recommend them, and are they effective in terms of stroke care, or getting care after a potential stroke?
Yeah, I mean, absolutely. Anytime that any device or anything that enhances access to be able to call 911 right away is important. Definitely not one over the other. But it's just important to remember that sometimes a stroke may actually affect the ability to process what's going on too. So, definitely have the ability, if it's just facial droop, speech difficulty, something, and the person is still able to think and push that button, it's definitely going to save that scenario.
Okay, perfect. Well, thanks so much again for sharing your expertise. I think that's all the time we have for today. I want to thank everyone for joining us today. These FCR webinars, they're free and we do them every month. Next time, we're going to be talking kind of more mental health and caregiving. I'm going to get a quick poll launch right now. But in the interim, again, you can find more about Family Caregiver Alliance and our webinars on our website, caregiver.org. And I'd like to thank you again for joining us. And in particular, my thanks to Irina for sharing her afternoon and her real skill in presenting this topic. Thanks again, Irina.
My pleasure. Very happy to be here.
Okay. Well, thanks so much, everybody. I think that's the end for us for this one. I'll leave the line open for about 5 minutes if you'd be willing to fill out that eval. Should take no more than about a minute to 90 seconds. And we, again, really appreciate your feedback. But for now, I think that's the end of this one. And I'd like to thank you all for spending your time with us. And I hope you have a great day.